Support for this work was provided by the New York State Health Foundation and Care Compass Network.
Good morning. My name is Jack Salo, and I'm the Executive Director of the Rural Health Network of South Central New York. Rural Health Network serves an 8-county region radiating out from Broome County and Binghamton. We've been in existence since 1998, and we offer a variety of services including transportation, food, community health worker, healthcare access services. We provide the AmeriCorps and Vista National Service program here in South Central New York, and we are also involved in community health education and rural health planning. Our approach to rural health work is somewhat holistic and comprehensive. We look at the fact that rural economies are struggling, losing population, aging. We think that we need to be involved in things like rural housing, obviously transportation, which is a core service we provide. So we're looking at it holistically and comprehensively, and that's one of the real drivers for our diverse service mix. It just made sense. We were doing much of the work that's needed in this arena of social determinants of health. We have a history of collaboration and networking that it was really a cornerstone of the DSRIP initiative, and it really is a cornerstone of value-based payment in terms of having a broader network of both clinical and community providers. So we felt like we were well positioned to be an active participant, and I would like to think certainly we learned a great deal about our healthcare partners, about healthcare reform. I would also like to think we contributed to the knowledge base of this work based on our experience.
So our community health worker model was a direct service line we were already deploying, basically via phone contact. Through DSRIP funding, we were able to expand our team from a 0.5 or a half-time position to more than 5.5 positions, actually working in the Broome, Tioga, and Delaware counties. Through that process, not only did we increase the community health worker capacity, but we improved our professional competencies. We got introduced to new evidence-based interventions. We improved our performance, and we came out as a leading community-based organization in that performance.
So the fruit and vegetable prescription program is a model where healthcare providers, usually in the primary care setting, but not always, can screen and enroll patients who participate in Medicaid and have a diagnosis or risk factors for cardiovascular disease or diabetes into this fruit and vegetable prescription program, and then they receive vouchers to spend on fresh fruits and vegetables. The funding has grown from our initial pilot project through Care Compass Network Innovation Funds to then receiving the second one and expanding. And late in 2019, we received new funding from the Mother Cabrini Health Foundation, which is now allowing us to continue the program and expand significantly. So from that initial investment through the innovation funds, we really had the opportunity to develop and pilot this whole new program model work through evaluation, sort of experiment with the workflows and see what was doing well, what we needed to change, and get to a place where we can now leverage this additional larger funding. And over the next year, we'll continue to be developing our solid evaluation, refining our systems for data and our return on investment to then, really try to develop some value-based payment, opportunities for the program.
There is no one way to be involved in value-based payment contracting, and I think that's an important point. If you're new to this opportunity, you may think that there's a set of rules and that you need to follow. And one of the things that I've learned, there's a great deal of diversity and different ways to be paid in value-based payment and to design a value-based payment contracting. And then if you think about how value-based networks form or value-based contracts emerge, it can happen through the managed care organization or health insurer. There could be the IPA ACO network that forms that would present that opportunity to a smaller rural community organization. You may have a larger partner, a healthcare system that you work with that you could inquire about what they're doing in terms of value-based payment contracting and whether or not there's an opportunity there. So there's many different ways that you could potentially end up in a value-based arrangement. When you are heavily dependent on any one funding source, you are vulnerable. So our strategy, and I think it's a good strategy regardless whether you're a single-purpose community organization or a multifaceted community organization, diversifying your funding base strengthens your organization, makes it more resilient to changes in the funding environment. And right now, governmental funding has been trending down for years. The philanthropic sector is dependent, on investments that can, be doing well or not. So funding diversification strengthens your ability to weather the loss of funding or a reduction in funding in any single funding area or sector. And I think it's a very important strategy regardless of whether you're, again, a single purpose or a multi-purpose community organization. When we're doing this work, the work that we do in rural New York State, typically, and this was certainly our experience, we are chronically underfunded and chronically under-resourced, and I'm talking about the community side of the work. When you have an opportunity to dramatically increase resources to serve your population and to realize your mission, it's great. These opportunities don't come along very often, and DSRIP was one of those opportunities, and we're hoping that value-based payment will continue to be an emerging opportunity to bring more resources to bear on what is, again, a chronically under-resourced environment that we work in. I think it's important to keep your eye on the prize, remember what your mission is. Healthcare is an environment that operates with billions of dollars. This is much different than what we experience. Again, their systems are larger, their budgets are larger, their administrative support services are larger. And I think one of the things we need to work to balance and to maintain is our sovereignty and our clarity around why we exist. One of the things that I'm fond of saying to my CBO partners is don't quit your day job. And really what that's about is up until 5 years ago when DSRIP rolled out, most of us that did not do a lot of work in the clinical healthcare environment, all of our funding was governmental, philanthropic, fundraising. Very little, if any of it, was what we would consider healthcare funding or dollars. So I think this is a great opportunity to move our missions forward, to access some resources that weren't available to us before. And I don't want to lose sight also, I think it's important, the best work that's been done in DSRIP, in my opinion, has been the forging of meaningful work and partnership between the community side and the healthcare and clinical side. The best practitioners of this work, I think, really get it, that only by working together are we going to improve the health status and the health outcomes of our people. And so that's a great reason to do the work. And again, there's an opportunity here to really make a difference in the lives of people and to improve the health of our population.
The reason for the project is that as we have been involved in this work as a rural organization, we found that rural and small community-based organizations were at somewhat of a disadvantage when it comes to taking advantage of the new payment opportunities provided by DSRIP and by value-based payment. And even though these community-based organizations have been working in the communities improving health and well-being for generations, we found that community-based organizations are not really used to communicating about the ways that their work impacts the healthcare system in a way that the healthcare system can understand. A lot of the times, smaller organizations don't have the need or the capacity historically to collect data in a way that the healthcare sector can understand. So within the project that we're doing, we are working with different community partners to better measure those types of interventions and then put them in return on investment terms so that essentially this will form sort of the bedrock of their value proposition as they engage in these value-based payment contracts. So in addition to the other measurement functions of the project, one of the things that we really wanted to do was bring to the forefront the voices of some of the community leaders who are doing this work, who are working to navigate through the DSRIP opportunity, to figure out what comes next in value-based payment. In this video series, you will hear from a variety of different leaders coming from community organizations that are small and large, that are rural. We heard from some government organizations. We've also heard of the different strategies that people are using to navigate the value-based payment and DSRIP opportunity. So you'll hear from a founding member of an IPA, an Independent Practice Association, but you'll also hear from some smaller CBOs that used the DSRIP opportunity to grow their programs. So we really wanted to give you a variety of different perspectives.
Support for this work was provided by the New York State Health Foundation and Care Compass Network.